You're listening to the Talking Air Filtration Podcast, where you get to know the people that make air filtration possible and help us all breathe easier. Because clean air matters.
We'll get insights from air filtration professionals and learn how they became successful in their careers. Along the way, we will discuss best practices, guidelines, trends, and challenges in air filtration in a variety of applications. We hope HVAC, air filtration, and indoor air quality pros, including business development, engineering, building owners, and facilities management, will enjoy the insights our guests will bring to this podcast.
We are thrilled to have Don Milton kick us off today to talk about making indoor spaces where we live, work, and play resistant to respiratory virus transmission. Don joins us from the University of Maryland School of Public Health. His research focuses on infectious bioaerosols, transmission of respiratory viruses, exhaled breath analysis, and environmental epidemiology. He will explore the scientific basis for this new paradigm and the profound challenge of its social implications. Please join me in welcoming Don Milton to the stage.
Well, thank you. It's great to be here. I don't mind preaching to the choir, and I assume many of you are members of the choir, have been talking about airborne infection and the importance of clean indoor air as a control strategy to mitigate the coronavirus pandemic and ensure health during flu seasons. And what I want to talk about today is what have we learned? How do we know what we know from the last 3 years? And where are we going with it? And where should we be trying to go with this? So what qualifies as the pandemic is over? Now we're no longer tracking infections the way we were early in the pandemic. Most people who get COVID test at home and it's never reported anywhere. So we don't really know how many infections there are out in the community. And so I would argue one criteria for saying we're normal is to look at the death rate. And is the death rate from pneumonia, influenza, and COVID back to normal? So in the chart here, we can see that there's this wiggly black line snaking across the bottom of the chart. And over on the left in 2018 and 2019, you see that the red line, which is the percentage of all deaths that are due to pneumonia, influenza, and now COVID, tracked along that line, those parallel lines. The lower one is called the seasonal baseline. That's how many people, what percent of people we expect every year to die of pneumonia. And then the upper line is called the epidemic threshold. And when it goes above that line, it's a bad flu year. And you could see that in 2018, we didn't have a terrible flu season. This little yellow hump here is the number of deaths and from influenza. And we went a little bit above the line. And in a bad year, we go up to about here. And we're tracking along, and then COVID hit. It was clearly not normal. The question is, are we back to normal? Here's where we are now. We're kind of headed back to normal. We've kind of got back down to where a really bad flu season would be. But we haven't got back down to the epidemic threshold, much less have we gotten back to the seasonal baseline. So is it over? Thinking about what to do about this stuff, we have to think about how do people get the flu? How do people get COVID? And there are 3 ways that we think respiratory transmission, the respiratory viruses transmit between people. Inhalation of fine particles floating in the air. Spray when you're close enough to get hit with a ballistic drop, which the medical profession calls droplets, but then they don't understand, to them, aerosols are all less than 5 microns. And there's been this incredible misconception going back to the 1940s and studies of William Wells with TB, and it's a long, long story that I'm not going to get into today. Or you could touch a contaminated surface, which might be contaminated because somebody sneezed on the surface or because somebody wiped their nose and then touched the desk or the doorknob or something. And a lot of the focus over the years has been on that mode of transmission and the spray, simply because they're tangible. You know, when you got hit with that spray, you can swipe surfaces and find stuff there. It's very hard to find things in air because you only need one infectious dose in the cubic meter of air you breathe every day in order to get infected. And we usually sample, a few liters of air, and we don't find much. And so it becomes difficult to prove that airborne transmission is happening, which is why in this diagram that was published in the New England Journal of Medicine following the SARS-1 epidemic, we called it the elusive pathway. This aerobiological pathway where we have a generation of particles that float in the air of a variety of sizes. They are dynamic because they're often wet when they're generated. They evaporate. UV light from sunlight or indoors can inactivate them. They dry out. They change size. They get concentrated. The pH changes. All kinds of stuff happens dynamically that affects whether the organism is still surviving. And then when we inhale it, where it ends up in our respiratory tract, again, depends on the size of the particles. So we've learned a lot over the last couple of decades about how these respiratory particles are generated. They're generated during quiet breathing with airway closure and reopening phenomenon. They're generated in the larynx when we speak and in the mouth when we articulate. The size distribution covers several orders of magnitude. And then, of course, how long they spend in the air is dynamic, as we were saying before. One of the peculiar things is that early on, many of the modelers during the 2020 were arguing that, well, we know what the concentration is in saliva, and we just say that that's the concentration in the aerosol particles, and therefore the tiny particles can't have much in them, and they're not very important. Well, unfortunately, that's not how the physics of this works. It turns out that most microorganisms are somewhat hydrous, and they partition into the thin films and bubbles. And so if there's a film bursting process, such as there is in the fine airways in the lung, the microorganisms concentrate into those thin films and end up orders of magnitude more concentrated in the resulting aerosol than they were in the source fluid. And so it turns out that the small particles are very important. And again, where they end up depends on what size they were when you inhaled them, and then they may grow dynamically if they're hygroscopic. And we showed in this work published in 2018 that there was a lot of virus in fine particles, and that it didn't really matter if you weren't coughing, you were still generating fine particles that contained influenza virus. And we were able to culture virus from the aerosol. And as a result, even our famous NIH NIAID director was on TV in 2018 saying, well, what did we learn from this paper? He was asked by Soledad O'Brien, and he said, well, we used to think that influenza was just transmitted by large droplets that only go a couple of feet. But now we know it can be in the fine particles that float on the air. You can breathe it in, and it can travel farther than that.
Are your air filtration personnel NAFA certified? Ask if they belong to NAFA and have their certified air filter specialist or NAFA certified technician designations. The CAFS and NCT designations are earned after rigorous exams and demonstrate that the air filtration professional has a high degree of knowledge and professionalism. To learn more about NAFA certifications, visit nafahq.org.
And then during the pandemic, we began seeing accumulating evidence that things did travel farther than that. In the restaurant transmission in Guangzhou, when the first cases came out of Wuhan, there was little filtration, but a lot of trapped recirculation of air in the back of the restaurant. In transmission to bus riders, where there were 2 buses of people that went to an event, and only people on one of the buses became infected. Then there was a restaurant in Seoul where 20 feet across the restaurant in the direction of airflow, people became infected who went in and out a different door than the people who came in with the infection. And we learned a lot about the way shedding happens, that indeed, as you might expect, because there's a lot of aerosol generation during vocalization, that we do see more coronavirus in the air when people are talking and singing than when they're simply breathing. And then there was this event in Australia where it turned out that the musician, the choir was not there. They knew they had a problem. So they only had one musician up in the choir loft playing the piano, facing this direction, singing. And yet all these people down on the floor of this large auditorium became infected. And when they were sequenced, it was the virus that this guy up here had. It was cultured from the air in a hospital in Florida. And in my lab, collecting exhaled breath using the same device we studied influenza with, we were able to culture it from the fine aerosol as well as from the swabs from the subject's nose. So this stuff is in the air. But when does it get in the air? And one of the problems that was recognized fairly early on is that a lot of the transmission was happening before the onset of symptoms. So up here we have the amount of transmission happening before and then after onset of symptoms. And this makes this a very difficult virus to control. This is why it was such a problem. And flu is probably doing the same thing. A lot of flu is transmitted right before or right as people come down with symptoms. So they went to work feeling fine and they go home a little early because they suddenly feel terrible, but they've been spewing virus out in the air all day. How do you stop transmission like that? That's very difficult. So one of the problems is that the rapid antigen tests we've been doing don't pick you up that early. It turns out that, and even nasal swabs done by PCR aren't very good that early. The one thing that does seem to work that early is PCR on saliva. But we're not doing much of that. We weren't doing much of that, but that is one approach. But the other side of the coin is that, testing is kind of like, okay, so you tested positive, but you probably already infected a bunch of people in the room. It's kind of the horses out of the barn. How do we get ahead of this? And, one of the things is to recognize that it's airborne and that that's what you're dealing with. And so there was, and then to recognize that putting masks on can make a difference. And that's where these papers here in 2018 with influenza, where we showed that masks cut out all of the bigger than 5 micron virtually, and more. This is a log scale, so this is a little more than half of the fine particle aerosol is cut out by just wearing a surgical mask. And this was then also done with seasonal coronaviruses using this same device, but in Hong Kong. And this paper came out in April 2020 and it's been downloaded more times than any other paper I've ever been a co-author on. It was downloaded over 2.1 million times in the first year. And so this was some of the basis for recommending that people wear masks. And we talked a lot about that early in the pandemic. And the problem with wearing masks, of course, is that it's the very bottom of the why can't I ever see it when I point over there? The hierarchy of controls. You've got to get people to do it right, do it all the time. Nobody wants to wear masks all the time. It's really sort of the last line of defense. And it's imperfect. It's because we know that surgical masks are only containing about half of the aerosol that the case is generating. And we've shown this similarly with COVID as we had with flu before. And it only cuts out about half of the fine aerosol that you're breathing because it leaks a lot around the edges. And this paper from Brigham and Women's Hospital in Boston showed, with sequencing data as accompanying it, that people who were wearing masks infected other people in the room, and some of whom were also wearing masks, but they were loose-fitting surgical masks. We're recently finishing up some work we did during Omicron, comparing the effectiveness we saw of cloth masks, surgical masks, KN95s, and N95s as source control for fine, less than 5 micron aerosol, and coarse, greater than 5 micron aerosol. And you could see that all of these masks work, but N95s work a lot better. And this is not people who've been trained, gone through a respirator training program and fit tested and so forth. This is people who were just handed one of these duckbill surgical N95s and said, squeeze the nose band to get it tight around your nose and after you put the band around your neck and over your head, and then breathe into the instrument. And it blocked 98% of the aerosol that they generated without any further training. I used to wear an elastomeric Envo mask a lot, and some of you may have seen my Twitter feed, which still has, I think, a picture of me wearing this when I got my first vaccine shot. But, these things have a lot bigger surface area, and so they have less breathing resistance. And personally, I did a quantitative fit test with it and got straight 200. So they actually do work. And they work even pretty well for untrained people. But it's still the bottom of the hierarchy of controls. You're trying to get people to wear PPE and to reduce exposure of others by behavioral modification. And we all know how well that has been received in many parts of our communities. So that's where engineering controls are really important. And this has been known in public health forever, that what's really important is to have controls that are always there. And that goes back to this problem of you don't know who's contagious, because if they come down with symptoms an hour from now, they were contagious now. But what are we doing about it? So if we can have some kind of control that blocks transmission without anybody having to do anything, that's key. And that's where ventilation has been really important. But ventilation has its limits, because this is from a paper published in 1991 about an outbreak of TB in a office building in Boston. And the square denotes the index case in that place who infected 40% of the people. What is that? Is that right? 40% of the people in the building. And if they increased the ventilation rate higher and higher, they could drive it down. But if you had cases who were even more contagious, which happens with TB, you couldn't really touch it with ventilation. And so what are you going to do? One of the problems is that we know that one of the key ways that Omicron, and basically right from the beginning, this pandemic propagated, had to do with super spreading events, where most people don't infect anybody, but a few people are in these highly connected nodes who seem to be very contagious and have lots of connections, and suddenly transmit it to a lot of people. Whether it's at a conference, I was talking this weekend with a colleague who had not had COVID until February of this year, went to a meeting with 12 people in a hotel conference, small hotel meeting, boardroom type room. 2 of the people had had COVID last winter and probably were not susceptible. 6 of the other 10 came down with COVID 2 days after the meeting. This was characteristic of SARS-1 as well, too. But SARS-1, we had a big advantage. People weren't contagious at the beginning until they got really sick. And that's why most of the transmission was happening in the hospitals. And so they weren't infectious before they had symptoms. So that makes things a lot easier. This is the problem here. And so how do you get on top of this? Well, for most of these cases that have, 1 or 2 or no other transmissions, you can control that with ventilation. And if we have a background level of ventilation and filtration, we can limit that. But these big clusters, we need to do something else. Lydia Mrwaska and colleagues put together this paper estimating the effect of low and high ventilation, and the triangles are speaking and the circles are breathing, on transmission of adenovirus, COVID, and measles down here. And what they are suggesting is that the number of secondary cases you can drive down with ventilation for many of these things. And they argue that you can do that with rhinovirus and influenza. I beg to differ about influenza. But anyway, it's clear that with some of these other infections, you just can't get there even with high ventilation. You're still going to have several people come away infected. So what do we do about that? And well, one thing is layers. So when you know you've got a problem, if you have baseline air changes per hour from ventilation and filtration, and then you say, okay, we got a problem, please put your masks on, you can make a big difference. And here is before and after a mask mandate in schools. And you see this is the community rate in the community that the schools were in, and this is the rate in the school population. And they closed the school and then said, okay, you can only come back, but we have to wear masks. And they brought it down to the community rate. That, and then this is looking at ventilation in schools, and districts that had ventilation had a similar reduction to institution of mask mandates. And then this work here from NIOSH in a simulated chamber, Bill Lindsay's work, shows that you combine these interventions, you have these layers, and it makes a big difference. But to really deal with those explosive events where you can't get on top of it with just ventilation, and you want to try to be ahead of the curve, or you think that you're not going to get people to wear masks in bars and restaurants, for example, then you need something else. And that's where UV comes in. This is from the Rocky Mountain laboratories of the National Institute for Allergy and Infectious Diseases and Vincent Munster's group, and they had hamsters separated by a quartz tube with the air going from one hamster to the recipient hamsters, and they had 100% infection rate of the hamsters downstream unless they turned on UV, in which case they got 0 transmission. So UV, this is 254, the old low pressure mercury vapor lamps, very effective at inactivating the virus. There's a long history of this. These are from the William and Mildred Wells's studies in suburban Philadelphia schools in 1941, where they were able to suppress the measles in the younger grades, which usually had very high rates, compared to the older grades, which usually had lower rates anyway, using UV. But when this was done in upstate New York, the area under the curve was no different between the unirradiated schools and the irradiated schools, because the kids rode the school bus for an hour. So if you don't treat everywhere that they might get infected, but it still had an important effect. Remember early on we were talking about flattening the curve so that we don't overwhelm hospitals, we can take care of people. I argue they did a pretty good job of flattening the curve. And this is against the most explosive virus known, measles, back well before the vaccine. And then there was the comparison of the hospital wing at Livermore that had upper room UV to the wings that didn't, where there was a 90% reduction of influenza in the patients in the wing that was protected. And the staff were going back and forth. They were this was the 1958 pandemic. They were bringing the virus in. And so they had a similar attack rate to the people the patients in the unirradiated part of the hospital. Doing laboratory experiments, we can show that that having good air movement with upper room UV with the old mercury vapor lamps is really important, and that if you optimize it, you can get between 20 and 1,000 equivalent air changes per hour with this technology. Newer technology is the far UV. You've probably heard about the 222 nanometer excimer lamps. It has the theoretical advantage that you can shine it directly down and on people because it doesn't penetrate the skin or eye and irradiate the air right between us. So potentially have a big impact on a shorter range transmission compared to the upper room UV. There is an issue with it produces a little bit of ozone. So if you don't have a baseline of a few air changes an hour of filtration or some carbon filters or something in the place, you would get into trouble with secondary aerosols. So this is a technology that should not be used on its own in unventilated spaces. This is an add-on where you already have a baseline of good ventilation and filtration, and now you want to have protection against super spreading events. So what can be accomplished if you put ubiquitous engineering controls in all the public spaces? Anyone going to take a guess based on that upstate New York study, what I'm going to tell you next about Westchester County study? This is an amazing study. Everybody's heard of William Wells. People haven't heard enough about Mildred Wells. She was the physician of the pair, and she did this study published with Wells and Hulla. William was not part of this project, apparently. They installed upper room UV everywhere they could in Pleasantville, New York, in the Village Movie Theater, in all the schools, in 3 Sunday schools, in the children's room of the public library, the Department of Health clinics, 3 churches, Girl Scout and Boy Scout meeting rooms, and the soda fountains. This is 1948, right? And then they used Mount Kisco, New York, as their control. And they traced where every case of measles and chickenpox over the next 2 years, and where the kid was exposed to somebody else with this infection. And they were able to significantly suppress the number of chickenpox cases, the 2 right-hand columns, but not measles. There was a big measles epidemic in very end of the study in a very rainy, humid period of time when kids were playing indoors at each other's houses a lot, and when the UV may have been somewhat less effective because of the high humidity. But there's still another interesting thing that happened, not only with chickenpox, but also with measles, which is if you look at the proportion of measles that was contracted by exposure in schools, it goes way down. Where people are getting measles is at home. And I think what this emphasizes is that we haven't been paying enough attention to homes. Bill Nazaroff published a review recently showing that the median house has about half an air change an hour in residential building in the United States. You think about it, what's happened during this pandemic. We had frontline workers going out, coming back to crowded families with extended family households and low ventilation and explosive transmission to vulnerable members of the family. And this is a big part of the social inequity that ensued from the pandemic. I live in a 1938 house that I haven't sealed up all that well. And when it's cold out, I've got about 2 air changes an hour to the stack effect in my house. And there's a lot of space for the small number of people living there. But in the next zip code over, we have lots of apartment buildings, very crowded, multiple families sharing small spaces. And that becomes a huge problem, a huge vulnerability, and a burden to those populations. So this slide is about the ventilation. This is from Bill Mazeroff's review, and looking at the geometric mean in many studies down around 0.3, actually. I was overestimating at 0.5. So really, really low. I'm not advocating that we put UV into people's houses. We don't need UV where there's half an air or a third of an air change an hour. We need ventilation and filtration. And it's in the places where you could potentially have explosive propagation within the population, in workplaces, in restaurants, and in bars, that we need things like UV, and maybe schools. So in conclusion, there's extensive evidence for airborne transmission, and layers make a big difference. The public spaces are important, but homes are important too, and we need to think about how are we going to get ventilation and filtration out, not just to the public spaces, but into our homes.
We have time for some questions, I believe.
The slide with the piano player and the singer. One of your first slides, and you showed the people getting infected, looked like 100 or 200 feet away.
In the auditorium in Australia.
In the auditorium, yeah. Mm-hmm. I'm just wondering, is there a unique identification of the virus coming from someone that you can, make that connection between the infectious person and the person that now has contracted the
Yes,
illness?
So it was on the left side of that, I didn't spend much time on it, but was the phylogenetic tree showing that there were essentially no mutations between the virus that was in the singer and the virus that was in the people down on the floor of the auditorium. So when you see a virus, when COVID mutates slowly and as when it transmits from person to person, if you catch it from me, there will be usually be one at most nucleotide change in the genetic sequence of the virus between the one I have and the one you have. And if somebody else in here has it and they transmit it to somebody, it will probably have, several mutations that have accumulated over the chain of transmission. We think that the big shifts in the variants of COVID are coming from people who are chronically infected, who have it for months because they're immunosuppressed. And then it develops whole, 20, 30, 40 changes, and then gets out to somebody else and starts propagating. But we're not talking about those big changes. We're just talking about the small changes that accumulate as it moves through a community. So that's how these things are tracked. And the same thing was done with the mask study at Brigham and Women's Hospital. The reason they knew that the transmissions had happened between people wearing surgical masks was because they had the identical sequence in the people.
I'll ask another one if you got a second. I just wondered, when I was looking at that, again, that slide, the distance from the infectious person to the furthest person away looked like several hundred feet. How long would the virus or a viral particle stay viable in the airstream, do you think, or is there information on that?
How long the virus survives and remains infectious in air is really interesting. There's some work coming out of the lab in Bristol that suggests that a lot of what's in the aerosol is quickly inactivated because the pH rises rapidly as the bicarb evaporates as CO2. What we see in these experiments is, the group in Florida was able to culture it from the air across the room. We were able to culture it in breath collected pretty quickly within a few seconds. But apparently, if there's enough, you don't have to have a huge survival fraction. I mean, even if people are shedding 1 million viruses an hour, and your survival fraction is 10 to the minus 4, you still got 100 at the end of an hour.
If that's it, then again, thank you, Dr. Milton. We appreciate everything that you're doing.
Thank you.
For NASA
Thank
and
you.
all your great research. Thank you.
Thanks for listening to the Talking Air Filtration Podcast, a production of the National Air Filtration Association. Clean air matters.